Hello and welcome to today's presentation. Today's presentation we're looking at um, hearing and equilibrium. So we're gonna remind ourselves about some facts about the ear and its major functions, right? So we'll be able to describe the anatomy and the structures of the ear, state the events of the physiology of hearing, explain some of the common disorders of the ear, and lastly state some of the nursing interventions that are involved in care of patients who have undergone some of the surgical interventions related to the ear, like the mastoid surgery. All right. So with us, we have some terms that you just need to familiarize yourself as we continue with the presentation. But let's take this time to review the anatomy of the ear, which is normally divided into three sections. We have the external, the middle, and the inner ear. So the work of the external ear is to do collect sound waves and channels them in the ear. Then the middle ear will convey the sound vibration to the oval window, and then now we have the inner ear that houses the receptors for equilibrium and hearing. Starting with the external ear, which is also the outer ear, it consists of the three major parts. We have the auditory, external auditory canal, and the eardrum. So the auricle is the pinna, and this pinna is a flap of elastic cartilage that is shaped like a flat end of a trumpet and is covered by the skin. We have the rim of the auricle, which is the helix, and the inferior portion, which is the lobus. So we have ligaments and muscles that normally attach this auricle or the pinna to the head. And the major role of the auricle is to act as a funnel so as to direct the sound waves into the ear canal. From there, we have now the external auditory canal, which is just but a tube running from the outer ear to the middle ear. It carries sound vibration from the pinna, which is the outside or the auricle, to the tympanic membrane. So this external auditory canal is about 2.5 centimeters long, and it lies within the temporal bone and leads to the tympanic membrane. So the tympanic membrane is also referred to as the eardrum, and it's a thin semi-transparent partition that will be found between the external auditory canal and the middle ear. The tympanic membrane is normally covered by epithelium, which is simple cuboid epithelium, and between the layers is connective tissue that is composed of collagen, elastic fibers, and fibroblasts. If you have a tear on the tympanic membrane, it is what is referred medically as a perforated eardrum. And this is majorly due to the presence of pressure from either a cotton swab, trauma, or a middle ear infection. So this tympanic membrane can also be examined by an instrument which we refer to as an otoscope. This otoscope helps us to eliminate and magnify the external auditory canal and the tympanic membrane. So near to the exterior opening, we have the ESC, that's the external auditory canal, will contain a few hairs and some specialized glands that we refer to them as the ceruminous glands. These ceruminous glands, they produce earwax, or what is medically referred to as cerumen. Is cerumen important? Yes, because the combination of hairs and cerumen normally helps a person prevent dust and foreign objects from getting into their ears. Also, cerumen also prevents damage of delicate skin of the external ear canal that can be orchestrated by water and some of these insects. So, how do we normally manage this cerumen? Well, studies have shown that cerumen normally dries up and falls off the ear canal. But we have some people who produce large amount of cerumen which can become impacted and can even muffle incoming sounds. So therefore the treatment of impacted cerumen is usually periodic ear irrigation or even removal of the wax with a blunt instrument, provided it's done by a trained medical personnel. So that marks the end of the external ear or the outer ear, right? We only had the pinna, which is the auricle, then we went to the external auditory canal, then we ended with the tympanic membrane. Let's proceed and now look at the middle ear. The middle ear, this one is an air-filled cavity, right? An air-filled cavity which includes the tympanic membrane that is part of the external that will be found laterally, and then the aortic capsule which will be found medially. In between, we have the middle ear cleft. The middle ear is normally connected by the eustachian tube to the nasopharynx, and this explains why infection from the nasopharynx is likely to be able to get to the middle ear because of this connection. And is a continuous with air-filled cells in the adjacent mastoid portion of the temporal bone. The eustachian tube is approximately 1 millimeter wide and 35 millimeter long, and does connect the middle ear to the nasopharynx. This eustachian tube is usually closed, but it can be opened by the action of the tensor veli palatine muscle, and these muscles will help open when a person is performing the Valsalva maneuvers, or when they're just yawning or swallowing. So this tube that does connects the middle ear to the nasopharynx is very important because it serves as a drainage channel for the normal and abnormal secretion of the middle ear. Equally, it also equalizes pressure in the middle ear with that of the atmospheric pressure. So the tympanic membrane can now be looked at in digits, in that we know it is about 1 centimeter in diameter and is very thin. In terms of color, it's fairly gray and translucent. This tympanic membrane, or the eardrum, as is commonly known, is normally consisting of 3 layers. We have the outer layer, which is normally continuous with the skin of the ear canal, the fibrous middle layer, which varies, so you find it will be present in pars tensa and absent in pars flaccida. And then lastly, we have the inner mucosal layer, which is continuous with the lining of the middle ear cavity. Approximately 80% of the tympanic membrane is composed of almost all the 3 layers of the 3 layers. That is the outer, the fibrous middle, and the inner mucosal layer. And this is what is referred to as the pars tensa. And then the other remaining 20% of the tympanic membrane will be lacking the middle ear, and that is what is referred to as the pars flaccida, right? Pars flaccida. Remember, the outer layer is made up of the epithelial tissue, while the middle layer is made up of the fibrous tissue. Lastly, the inner ear is made up of the mucosa, all right? So, the absence of the fibrous layer in the pars flaccida makes it more vulnerable to these pathological disorders than the pars tensa. Equally, tympanic membrane has distinguishing landmarks, like we have the umbo, we have the handle of the malleus, the manubrium, lateral process of the manubrium, anterior malleal fold. We have the pars flaccida, okay, what is referred as the chaparral membrane, and we have the pars tensa, which makes up around 80%, right? Remember, pars flaccida only accounts for around 20%. Then we have the annulus, right? Remember, the tympanic membrane protects the middle ear and also conducts sound vibration from the external canal to the ossicles. Sound pressure here is magnified 22 times as a result of transmission from a large area to a small area. Now we move to the auditory ossicles, right? All right, guys. Auditory ossicles are bones found in the ear, and they are named so because of their shapes. So we normally have the abbreviation MISHAP, where M stands for malleus, incus, then steps, or rather hammer, anvil, and stirrup. Okay, so we have MISHASH, right? So we have the handle of the malleus. The handle of the malleus normally attaches to the surface of the tympanic membrane, right? And it's here. While the head of the malleus, now the head of the malleus here is the one that will be articulating with the middle bone of the ear, right? And the middle ear of the bone, that's the incus, is going to articulate with the head of the steps, right? Here is the articulation, right? And you can be able to see the incudostapedial joint here, okay, which is a synovial joint. Then we have now the base of the steps, right? The base of the step, this one is what fits in the oval window, oval window. Then directly below the oval window, we have another opening that we refer to as now the round window, and this one round window is enclosed by a membrane that is called the secondary tympanic membrane. Now, beside the ligaments, we also have two tiny skeletal muscles which also attach the ear ossicle. The first one we have the tensor tympani muscle followed by the stapedius muscle. The tensor tympani muscles is normally supplied by the mandibular branch of the trigeminal nerve, which is cranial number 5. And it limits movement and increases tension of the eardrum to prevent damage to the inner ear from loud noises. The stapedius muscle, which is supplied by the facial nerve, cranial number 7, is the smallest skeletal muscle in the body. So by damping large vibration of the steps due to the loud noises, it will protect the oval window, but it can also decrease the sensitivity of hearing. So for this reason, we normally assess the paralysis of the stapedius muscle. Paralysis of the stapedius muscles is associated by hyperacusia, which is abnormally sensitive hearing. So besides, it also takes a fraction of a second just for the tensor tympani and stapedius muscles to contract, right? Just a fraction of a second. So that means it can be able to protect the inner ear from prolonged loud noises. And this is just with the exemption of the brief ones like the gunshot wounds, right? The gunshot sound, right? The anterior wall of the middle ear contains opening that leads directly to the auditory, this is pharyngotympanic tube, commonly referred to as the eustachian tube. So the auditory canal, which consists of both bone, elastic cartilage, connects the middle ear with the nasopharynx, which is the superior portion of the throat. It is normally closed at its medial, that is the pharyngeal end, right? Remember, the eustachian tube connects the middle ear to the nasopharynx, which is the upper part of the throat, and it helps equalize pressure with the middle ear at the atmospheric pressure, right? You can see the eustachian tube, right? So during swallowing and yawning, it opens, allowing air to enter or leave the middle ear until the pressure in the middle ear equals the atmospheric pressure. Okay, remember, ear normally pops as the pressure equalizes. Okay. When the pressure are balanced, the tympanic membrane vibrates freely as sound waves strike it. If the pressure is not equalized, intense pain, hearing impairment, ringing the ears, and vertigo could develop. We have the auditory tube, also a route for pathogens to travel from the nose to the throat to the middle ear, causing most common type of ear infections like the otitis media. From there we go to the inner ear. The inner ear or the eternal ear is also referred to as the labyrinth. Why is the inner ear referred to as the labyrinth? Because of its complicated series of canals, right? So the inner ear is housed deep within the temporal bone, and it consists of organs for hearing like the cochlea, and the balance of which balance is facilitated by the three semicircular canals, which are abbreviated as LAPA, where the the lateral semicircular canal is horizontally oriented, while the anterior and posterior are vertically oriented. Okay, and this also the inner ear is also has some cranial nerves like cranial number 7, the facial nerve, and cranial number 8, the vestibulocochlear nerve. So the cochlea and semicircular canals are housed in the bony labyrinth. This bony labyrinth surrounds and protects a membranous labyrinth which is bathed in a fluid called the perileaf. Starting now with the membranous labyrinth. Remember, for you to get the bony labyrinth, we can see the different in terms of color and the membranous, all right? So, but the bony covers the membranous, all right? So the membranous labyrinth consists of the uticle, the saccule, the cochlear duct, semicircular canals, and the organ of Corti. The membranous labyrinth contains a fluid that is referred to as the endolymph, right? So the three semicircular canals, that is the posterior, superior, lateral, they lie at 90 degrees to one another. They do contain sensory receptor organs arranged to detect rotational movement. These receptor end organs are stimulated by changes in the rate or direction of an individual's movements. The uticle and the saccule are involved in linear movements, right? Remember, endolymph is rich in potassium and low in sodium and calcium, while perilymph is rich in sodium and low in potassium and calcium. This difference in concentration normally allows for a positive endocochlear potential for the ear. The organ of Corti is located in the cochlea, and cochlea is a snail-shaped bone tube of about 3.5 centimeters long with 2.5 spiral tracts. Right, the membranes that separate the cochlear duct. We have membranes that do separate the cochlear duct. All right, the cochlear duct is the skull media here. Okay. From the scala vestibule and the scala tympani, right? Scala tympani from the basilar membrane. The organ of Corti is located on the basilar membrane, right? The basilar membrane, stretching from the base to the apex of the cochlea. So as vibrations enter the perileaf at the oval window and then travel along the scala vestibule, they pass through scala tympani and then they enter the cochlear ducts and cause movement of the basilar membrane. The organ of Corti is also referred to as the end organ of hearing. Its work is to transform mechanical energy into neural activity and separate sounds into different frequencies. The electrochemical impulse will travel through the acoustic nerve to the temporal cortex of the brain to be interpreted as meaningful sound. In the internal auditory canal, we have the cochlea, which is acoustic nerve, will arise from the cochlea, then join the vestibular nerve, arising from the semicircular canals, auricle and saccule, to become the vestibulocochlear nerve, right? That is cranial number 8. This canal also houses the facial nerves, which is cranial number 7, and the blood supply supplies blood to the ear, right? Okay. So what are some of the functions of the ear, right? Function of the ear, of course, what is always associated with the ears is hearing, right? And this hearing is normally conducted in two pathways. We have the air and the bone conduction. So sound transmitted by air conduction will travel over air field, and the air field is the external ear, right? And middle ear through vibrations of the tympanic membrane and the ear ossicles. Sound transmitted by bone conduction will travel directly through bone to the inner ear by passing the tympanic membrane and the ear ossicles. So normally, air conduction is much more effective. That's why we always say that air conduction is longer than bone conduction. This is the normal hearing findings, and is also a normal finding in somebody with sensorineural hearing loss. However, defects in the tympanic membrane and interruptions of the ossicular chain disrupt normal air conductions, which result in loss of sound to sound to pressure ratio, subsequently resulting into a conductive hearing loss where the bone conduction now will be greater or longer than the air conduction. So sound enters the ear through the external auditory canal, and it will cause the tympanic membrane to vibrate. This vibration will transmit sounds through the lever action of the ear ossicles to the oval window as mechanical energy. This mechanical energy will then be transmitted through the ear fluids, that is the perileaf, then the endoleaf, into the cochlea, stimulating the ear, the hair cells, and subsequently it will be converted now to electrical energy. This electrical energy will travel through now the vestibulocochlear nerve to the CNS, where it will be analyzed, interpreted in its final form as sound. So this vibration transmitted by the tympanic membrane to the ear ossicles of the middle ear are transferred to the cochlea logged into the labyrinth of the ear. The steps rocks, causing vibrations in the fluids contained in the inner ear. These fluids waves cause movement of the basilar membrane to occur, that then stimulate the hair cells of the organ of Corti in the cochlea to move in a wave-like manner. The movements of the tympanic membrane will set up electrical currents that stimulate various areas of the cochlea. So the hair cells then set up neural impulses that are encoded, then transferred to the auditory cortex in the brain, where they are decoded into sound messages. The footplate of the steps will receive impulses transmitted by the incus and then the malleus from the tympanic membrane. We have the round window, which opens on the opposite side of the cochlear duct, is protected from the sound waves by the intact tympanic membrane, and this permits motion of the inner fluids by sound wave stimulation. So in the case, for example, in the normally intact tympanic membrane, sound waves will stimulate the oval window first, then we'll have a lag period which occurs before the terminal effect of stimulus reaches the round window. So this lag phase is important, and if it is changed, however, like in the case where we have a perforation of the tympanic membrane, okay, so it is going to allow now sound waves to impinge on the oval and round window simultaneously, when actually in the normal case it should first of all hit the oval then take some time before it gets to the round window. This effect cancels the lag and prevents the maximum effect of inner ear fluid mobility and its subsequent effect on stimulating the hair cells in the organ of Corti, resulting into a reduced ability to hear. So what about the balance and equilibrium? You know that the body balance is normally maintained by the cooperation of muscles, joints of the body. That is the proprioceptive system. And we also have the eyes, which forms the visual system. And lastly, the labyrinth, especially the vestibular system. So these areas will send their informations about equilibrium or balance to the brain, specifically the cerebellar system, for coordination and perception in the cerebral cortex. Then the brain will obtains its blood supply from the heart and the arterial system. A problem in any of these areas, like the atherosclerosis or impaired vision, can cause balance disturbance. The vestibular apparatus of the inner ear will provide feedback regarding the movement and the position of the body and the head, right? Okay. So we can also observe how the ear is through inspection of the external ear. We can just inspect, and we can do it through direct inspection, all right, or direct palpation. So like the auricle, the pinna in this case, and surrounding tissue should be inspected for deformities, lesions, discharge, size, symmetry, angle of attachment to the head. So when you have manipulation of the auricle eliciting pain, right, we say that we could suspect that this patient is suffering from acute external otitis, right? Because manipulation of the pinna should not result in pain, okay? We can also do palpation on the mastoid area. So when we have tenderness, of course, in a normal case, we don't need to, the patient does not need to show any signs of tenderness, right? But in the case the patient is demonstrating tenderness on palpation, then we could suspect that probably this patient is suffering from acute mastoiditis or inflammation of the posterior ocular nodes. We're also going to suspect sebaceous cyst and typhoid when we see the subcutaneous mineral deposits on the pinna. We also have a flaky scalines on or behind the auricle, and this could demonstrate or indicate that the patient is suffering from seborrheic dermatitis. We could also do otoscopic examination where the tympanic membrane will be inspected using the otoscope as we had indicated earlier, or we could also do indirect palpation with a pneumatic otoscope. So this one is used to examine auditory canal, the ESC, near the meatus, and the tympanic membrane. So the otoscope should be held in the examiner's right hand, just like a pencil hold position, with the examiner's hand pressed against the patient's face. Okay, and you hold the otoscope like a pen between the thumb and the index finger. So you use your right hand for examination of the right ear and left hand for the left ear. Slowly insert around 1 to 1.5 centimeters just past the air of the lateral canal, and then you gently pull the pinna upwards and backwards and outwards for adults. Remember, you have to be careful because this may cause the patient discomfort if they have inflammation in the external auditory meatus, okay? So you have to look at that. So you inspect the tympanic membrane. If it's bulging, it may lose its bony landmarks that we had mentioned, and usually is a sign of pus in the middle ear. If retracted, it will have amputated bony landmarks and may signify dysfunctional eustachian tube. Because the distal portion of the canal is bony and covered by sensitive layer of epithelium, only light pressure can be used without causing the pain. The external auditory meatus is examined for discharge, inflammation, and foreign body. The healthy tympanic membrane, as we had indicated earlier, is normally palely gray and is positioned obliquely at the base of the canal with landmarks such as the umbo, the manubrium of the malleus, the short process of the malleus, the anterior fold, the pars flaccida, which makes about 20%, and the pars tensa, which makes up of 80%. We also have a cone of light at 5 o'clock. Then we have the annulus and the incus and the posterior fold. We can also do a whisper test, like a whisper test. So a whisper, you whisper a number of or word approximately 6 centimeters, 60 centimeters from the patient ear, and ask the patient to repeat them. For the whisper test, you have to exclude one ear from the testing, and the examiner covers the untested ear with the palm. When the examiner whispers softly from a distance of 1 to 2 feet from the unoccluded ear out of the patient's sight, the patient with normal acuity can correctly repeat what was whispered. Right? We can also look at the Weber test. This one uses bone conduction to test lateralization of sounds, right? The apparent location of the source of sound in the head. So we have a tuning fork of ideally 512 Hz. Will be set in motion by grasping it firmly by its stem and tapping it on the examiner's knee or hand, and then will be placed on the patient's head or forehead, right? Okay, so a person with normal hearing hears these sounds equally in both ears, left and right, or can describe the sound as being centered at the middle of the head. What about the deformities? A person with conductive hearing loss, such as from otosclerosis or otitis media, will hear these sounds better in the affected ear, while a person with sensorineural hearing loss resulting from damage to the cochlea or vestibulocochlear nerve will hear these sounds in the better ear. All right. The Weber test is normally used for detecting unilateral hearing loss. That takes us to the Rhine test. And the Rhine test here, the examiner shifts the stem of this vibrating tuning fork between two positions. That is 2 inches from the opening of the ear canal, just to look at the air conduction. So, and then against the mastoid bone for bone conduction. So as the position changes, the patient is asked to indicate which tone is louder or when the tone is no longer heard. Rhine test is normally used for distinguishing between conductive and sensorineural hearing loss. So when conducting Rhine test, a person with normal hearing will report that air conducted sound is louder than bone. So AC is greater than BC. For a person with conductive hearing loss, they'll find that bone conducted sound, they will be long or as long and longer than air conducted now. Now BC will be greater than BC will take longer than air conduction. So this guy has conductive hearing loss. While a person with sensorineural hearing loss, will hear air conducted sounds longer than the conducted, and will be almost the same like the normal hearing sounds, right? What about the diagnostic evaluation? Well, most diagnostic procedures are available to measure the auditory and the vestibular systems indirectly. These tests are normally performed by an audiologist, and prior to these tests, the nurse has to explain the procedure to the patients. So we could have like audiometry, which is the single most important diagnostic test in determining hearing loss. Auditory testing could be of two kinds. We could have pure tone audiometry or speech audiometry. Pure tone audiometry, you find that the sound stimulus consists of a pure or a musical tone. That is, the louder the tone before the patient perceives it, the greater the hearing loss, while the speech audiometry is in which you have spoken word is used to determine the ability to hear and discriminate sounds and words. So we look at the frequency, we look at the pitch, right, and the intensity. What about tympanogram, okay, or the impedance audiometry? This one measures middle ear muscle reflex to sound stimulation and compliance of the tympanic membrane by changing the air pressure in a sealed ear canal. So compliance is impaired with middle ear disease, right? Okay. We also have audiometry brainstem response, which is detectable. It is a detectable electrical potential from the cranial nerve 8 and the ascending auditory pathways of the brain in response to sound stimulation. So we find electrodes will be placed on the patient's forehead. Then the acoustic stimuli, the clicks are made in the ear. The resulting of electrophysiological measurements can determine at which decibel level a patient hears or whether there are any impairments along the nerve pathways, like a tumor on the cranial number 8, the vestibulocochlear nerve. So this audiometry brainstem response normally tells us how the inner ear, that is the cochlea, and the brain pathways are hearing or are working. You may also hear it called audiometry evoked potential, AEP. We also have electrostenography, and this measurement is a measurement and graphic recording of changes in electrical potential created by the eye movements during spontaneous, positional, or calorical evoked nystagmus. It is used to assess oculomotor and vestibular systems and their corresponding interaction. This test normally helps diagnose conditions such as the Meniere's disease and tumors of the internal auditory canal or posterior fossa. Any vestibular suppressants such as the sedatives, tranquilizers, antihistamines, and alcohol should be withheld for 24 hours before this test. So this test is just used to evaluate people with vertigo, that is a false sense of pining or motion that can cause dizziness, and certain other disorders like the Meniere's disease that we have mentioned. So electrodes will be placed at locations above and below the eye just to record electrical activity. We also have the platform postography, sinusoidal harmonic acceleration, or the rotary chair, as some of the tests that are normally carried to find out the ear problems. So we have specific conditions that affect the three major parts of the ear. Remember, we talked of the external ear, middle ear, and the inner ear. So starting with the conditions of the external ear, right? Remember the external ear, we say it's made up of which parts? We have the pinna, which is the outside or the auricle. Then we have the external auditory canal or meatus, and then part of the tympanic membrane. So in those parts, we have conditions like cerumen impaction, external otitis or otitis externa, foreign bodies, malignant external otitis, and gaping hearing puncture. Remember, for the cerumen, we say it is normally produced by those cells in the external auditory canal. And this works does not usually need to be removed, okay, but impaction occasionally occurs, and this can cause otalgia, which is a feeling of a feeling sensation of fullness or pain in the ear with or without hearing loss. So accumulation of cerumen can cause a hearing loss and a significant, especially significant in elderly population. So attempts to clear the external auditory canal with matches, earpins, and other implements are dangerous because trauma to the skin, infection, and damage to the tympanic membrane can occur. So how is it managed? This cerumen can just be removed through irrigation, suction, or instrumentation. Unless the patient has a perforated eardrum or an inflamed external ear, we just do gentle irrigation. Usually helps just to remove this impacted cerumen. This is particularly if it is not tightly packed in the external auditory canal. So for successful removal, the water stream must flow behind this obstructed cerumen just to remove it first laterally, then out of the canal. To prevent injury, we have to use the lowest effective pressure in this case. If the eardrum behind is impacted, behind that imperfection is perforated, then water can enter the middle ear, producing acute vertigo and infection. If irrigation is unsuccessful, we can do direct visual mechanical removal can be performed on a cooperative patient by a trained healthcare provider. Remember, instilling a few drops of warmed glycerin or mineral oil or even a half-strength hydrogen peroxide into the ear canal for around 30 minutes can soften cerumen before its removal. We have ceruminolytic agents such as peroxide in glycerin, which are available, but these compounds are likely to cause allergic dermatitis reactions. So we try and avoid or limit their use. So using any softening solution or treat 2 to 3 times a day for several days generally sufficient. If cerumen cannot be dislodged by this method, instruments such as cerumen curette, oral section, and the binocular microscope for magnification can also be used. The second condition affecting the external ear is the foreign bodies in the ear. Some objects can be inserted either intentionally into the ear by others who may have been trying to clean the external canal or relieve itching, or by children who just introduce items like the peas, the beans, the pedals, the toys, or the pits. So also insects can also enter the ear canal, especially in low class citizens. In either case, these effects may range from no symptoms to profound pain and decreased ability to hear. So how do you manage? You remove this foreign body from the external auditory canal, which sometimes can be challenging. All right, but currently we have 3 standard methods of removing foreign bodies for removing the foreign body, just as for removing the cerumen, like irrigation, suction, and instrumentation. All right, the contraindication for irrigation are the same. Right, if there is some perforation, I know the fluids could get into the middle ear and cause some vertigo, which should be avoided. Foreign vegetable bodies and insects tend to swell, and thus irrigation sometimes is contraindicated. So usually an insect can be dislodged by just instilling mineral oil, which will kill the insect and allow it to be removed. Attempts to remove a foreign body from the external canal may be dangerous in unskilled hands. The object may be pushed completely into that bony portion of the canal lacerating the skin and perforating the tympanic membrane. In rare circumstances, foreign bodies may also be extracted in the operating room with the patient under GA, right? The third condition affecting the external ear is the external otitis or otitis externa, which is also referred to as the swimmer's ear, right? The swimmer's ear condition. This is simply an inflammation of the external auditory canal. Okay, external auditory canal inflammation is referred to as the external otitis. It's caused by water in the ear canal. That's why it's referred to as the swimmer's canal. And we have trauma to the skin of the ear canal and permitting entrance of organism into the tissues, or systemic conditions like vitamin deficiency, okay, disorders. All right. Bacterial and fungal infections are the most commonly encountered here, and the most common type of bacterial pathogen associated with the otitis externa is the Staphylococcus aureus and Pseudomonas species. The most common fungus as isolated in both normal and infected ear is the Aspergillus, right? But otitis, external otitis is often caused by dermatosis such as the psoriasis, eczema, and seborrheic dermatitis. Even allergic reactions to the hair spray, hair dye, permanent wave lotions can cause dermatitis, which clears when offending agent is removed. We have some symptoms of inflammation of the external auditory canal, where patients usually report pain, discharge from external auditory canal, oral tenderness, usually not present in the middle ear infections, and occasionally fever, cellulitis, and lymphadenopathy. Other symptoms include pruritus, hearing loss, or feeling of fullness. On otoscopic examination, the ear canal will be found to be erythematous and edematous. We have a discharge where we have a yellow or green foul discharge showing infection, especially by the Staphylococcus. Hair-like black spots may also even be visible in fungal infections. In terms of management, the principles of therapy are aimed at relieving the discomfort, reducing the swelling of the ear canal, and eradicating the infection. So patient may require analgesic medication for the first 48 to 92 hours. If the tissues of the external auditory canal are edematous, we could do a wink should be inserted just to keep the canal open so that fluid medication, e.g. the Barrow solution, the antibiotic otic preparation can be introduced. These medications may be administered by a dropper at room temperatures. Such medication usually combine antibiotic and corticosteroid agents just to soothe the inflamed tissues. For cellulitis or fever, systemic antibiotics can be prescribed, while for the fungal disorder, antifungals can also be indicated for that. So nurses need to teach this patient not to clean the external auditory canal with these cotton-tipped applicators, to avoid swimming, and not to allow water to enter into the air when showering, for a case. A cotton ball can also be covered in a water-insoluble jelly such as petroleum jelly and placed in the ear as a barrier to water contamination. Infection can also be prevented by using antiseptic otic preparation after swimming, e.g. swim dry, ear dry, right? Unless there is a history of tympanic membrane perforation or current infection. The fourth example of an infection affecting the external ear is the malignant external otitis. This is a more serious condition, although it's a rare kind of infection. Malignant external otitis is also referred to as the temporal bone osteomyelitis. It's a progressive, debilitating, and occasionally fatal infection of this external auditory auditory canal, and surrounding the tissues and also the skull. We have Pseudomonas angiorrhea, which is usually the infecting organism in patients with low resistance to infections, like patients with diabetes. Successful treatment includes control of diabetes, administration of antibiotics, usually intravenous, and also aggressive local wound care. We have standard parenteral antibiotic treatment, which includes the combination of anti-pseudomonal agent and an aminoglycoside, both of which have potential serious side effects. Because aminoglycosides are nephrotoxic and endotoxic, serum aminoglycoside levels and renal and auditory function must be monitored during the therapy. You are also supposed to engage the patient to sign consent on the possible side effects caused by the aminoglycosides. Local wound care includes limited debridement of the infected tissue, including the bone cartilage, depending on the extent of that infection. Lastly, we have the masses of the external ear as the fifth disorder of the external ear, where we have the exitosis, which are small hard bone protrusion in the lower portion of the bony portion of the ear canal, and they usually occur bilaterally. So skin covering exitosis is normal. So many people think exitosis are caused by excessive exposure to cold water, as in scuba diving or the surfing. The usual treatment, if any, is surgical excision. Malignant tumors are also found in the external ear. Most of the common ones here are the basal cell carcinomas of the pinna and squamous cell carcinoma of the ear canal. If untreated, squamous cell carcinoma may spread through the temporal bone, causing facial nerve paralysis and hearing loss. Carcinomas may be treated surgically. We have gaping earring puncture as the sixth condition affecting the external ear, and it results from wearing heavy pierced earrings for a long time or after an infection or as a reaction from the earring or other impurities in the earring. One or more gaping punctures may result from earring more than one earring. Whatever the cause is, this deformity can only be corrected surgically. So the edges of the perforations are excised on the lateral and the medial surfaces of the ear. So next we look at now the middle ear infections, and the middle ear infections include the tympanic membrane perforation, otitis acute, otitis media, chronic otitis media, the serous otitis media, otosclerosis, and the middle ear masses. Tympanic membrane perforation is usually caused by either an infection or trauma. Sources of trauma could be like a skull fracture, explosive injury, or a severe blow to the ear. Less frequently, you find that perforation is caused by foreign objects, e.g. the cotton-tipped applicators, the bobby pins, or the keys that have been pushed too far into the external auditory canal. In addition to tympanic perforation, we have injury to the ossicles, and even the inner ear may result from this kind of infections. So attempts by patients to clear the external canal should therefore be discouraged. So during an infection, you find the tympanic membrane can rupture if the pressure in the middle ear exceeds the atmospheric pressure in the external auditory canal. So although most tympanic perforations heal spontaneously within weeks after rupture, some may take several months to heal. So some perforation persists because scar tissue grows over the edges of that perforation, preventing extension of the epithelial cells across the margins and final healing. In the case of a head injury, for example, or temporal bone fracture, a patient is observed for the evidence of cerebral fluid otorrhea or rhinorrhea, which is a clear watery drainage from the ear or the nose, respectively. While healing, the ear must be protected from water. Okay? Surgical management, you find that this perforation may not heal on their own, and this may require surgical intervention. And the decision to perform a tympanoplasty, which is a surgical repair of the tympanic membrane, is usually based on the need to prevent potential infection from water entering the ear or the desire to improve the patient's hearing ability. It is surgical management, surgical interventions on such patient would be performed on an outpatient basis, where tympanoplasty may involve a variety of surgical techniques. In all the techniques, tissue is replaced across the perforation just to allow healing. Surgery is usually successful in closing the perforation permanently, improving hearing process. The second condition affecting the middle ear is the AOM, that is acute otitis media, which is an acute infection of the middle ear and usually lasting less than 6 weeks. The primary cause of acute otitis media is usually Streptococcus pneumoniae, Haemophilus influenza, and Moraxilla catarrhalis, which will enter the middle ear through the eustachian tube that is connecting the nasopharynx and the middle ear. So this is caused by obstruction related to upper respiratory infections, inflammation of surrounding structures like sinusitis, adenoid hypertrophy, or allergic reactions or allergic rhinitis. So bacteria can enter the eustachian tube from the contaminated secretions in the nasopharynx and the middle ear of the tympanic membrane perforation. Then you have a purulent exudate, usually present in the middle ear, resulting in a conductive hearing loss. So this condition usually is unilateral in adults and may be accompanied by otalgia. So the pain here is relieved by spontaneous perforation or therapeutic incision of the tympanic membrane. So on a patient with acute otitis media who reports relief of pain without any medical intervention, you should suspect that probably there is spontaneous perforation. The other symptoms of acute otitis media could include drainage from the ear, patient presenting with fever, and patients having decreased ability to hear, okay, the hearing loss. On otoscopic examination, you find that the external auditory canal may appear normal. The patient may report no pain with movement of the auricle. The tympanic membrane may be erythematous or often bulging. In terms of managing acute otitis media, remember the outcome of this management will depend on the efficacy of the therapy. That is the prescribed dose of an oral antibiotic and the duration of the therapy, the virulence of the bacteria, and the patient's status of the physical status of that particular patient. But we expect with early and appropriate broad-spectrum antibiotic therapy, otitis media should resolve with no serious sequelae. If drainage occurs, an antibiotic otic preparation is usually prescribed. The condition may become subacute, lasting 3 weeks to 3 months with persistent purulent discharge from the ear. Rarely does permanent hearing loss occur. Secondary complications involving the mastoid and other serious intracranial complications such as meningitis, brain abscess, could occur, although they are very rare. An incision in the tympanic membrane, also known as laryngotomy or the tympanoplasty, may also be performed. The tympanic membrane, find that in this surgery, the tympanic membrane will be numbed with a local anesthetic. This could be the phenol or by the iontophoresis, that is electrical current flowing through lidocaine and epinephrine solution just to numb the ear canal and the tympanic membrane. This procedure is usually painless and takes less than 15 minutes. Under microscopic guidance, an incision will be made through the tympanic membrane to relieve pressure and to drain this serous and purulent fluid from the middle ear. Normally, this procedure is unnecessary for treating acute otitis media, but it may be performed if the pain persists. Myringotomy also allows the drainage to be analyzed, that is by culture and sensitivity, so that the infecting organism can be identified and appropriate antibiotic therapy prescribed for this particular patient. Incision normally heals within 24 to 72 hours. If the episode of acute otitis media reoccur, there is no contraindication of ventilating. We find that you can use a ventilating or a pressure equalizing tube which will be inserted in such case. This ventilating tube, which temporarily takes the place of the eustachian tube in equalizing pressure, is retained for 6 to 18 months. The ventilating tube is then excluded from the normal skin migration of the tympanic membrane, with a whole healing in the nearly every case. Ventilating tubes are more commonly used to treat recurrent episode of acute otitis media in children and adults, right? You can be able to see our ventilating tube, right? They also refer to as the tynoplasty tubes or myringotomy tubes or pressure equalizing tubes. They're simply tiny and hollow tubes that surgeons place into the eardrums during surgery, and this one allows air into the middle ear, okay, and it keeps fluid from building up in the middle, in the eardrums. The other condition affecting the middle ear is serous otitis media, or simply middle ear effusion. It implies fluid without evidence of active infection in the ear. This fluid results from a negative pressure in the middle ear caused by eustachian tube obstruction. This condition is primarily found in children. When it occurs in adults, an underlying cause of this eustachian tube dysfunction must be looked at. Middle ear effusion is frequently seen in patients after radiation therapy or barotrauma, and in patients with eustachian tube dysfunction from concurrent respiratory infection or allergy. Barotrauma results from sudden pressure changes in the middle ear caused by changes in the barometric pressure, as in the scuba diving or the airplane descent. A carcinoma, for example, the nasopharyngeal cancer, can obstruct the eustachian tube and should be ruled out in adults with persistent unilateral serous otitis media. Patients with middle ear effusion may complain of hearing loss, fullness in the ear, or a sensation of congestion, or perhaps even popping and cracking noises, which normally occur as the eustachian tube attempts to open. The tympanic membrane appears dull on otoscopy, and air bubbles may be visualized in the middle ear. Usually the audiogram shows a conductive hearing loss. Serous otitis media need not to be treated medically unless the infection occurs, like the case of acute otitis media. If the hearing loss is associated with middle ear effusion is a problem for the patient, a myringotomy can be performed and a tube may be placed to keep the middle ear ventilated. Corticosteroids in small dosages may be used to decrease the edema of the eustachian tube in the cases of the barotrauma. Decongestants so far have shown not to be effective. A Valsalva maneuver, which forcefully opens the eustachian tube by increasing nasopharyngeal pressure, should be performed with caution. So, because performing such procedure might worsen pain or the perforation of the tympanic membrane. Next, we have the chronic otitis media. This is as a result of repeated episodes of acute otitis media causing irreversible tissue pathology and persistent perforation of the tympanic membrane. So chronic infections of the middle ear, of the middle ear damage the tympanic membrane, then they destroy the ossicles and then can also involve the mastoid. So before the discovery of antibiotics, infection of the mastoids were life-threatening, but the use of medication in acute otitis media has made acute mastoiditis a rare condition, especially in developed nations. Patients with chronic otitis media can present with varying degrees of hearing loss, the presence of a persistent or intermittent foul-smelling otorrhea. Pain is not usually experienced except in cases of acute or mastoiditis when the post-auricular area is tender to the touch and may be erythematous or edematous. Otoscopic evaluation of the tympanic membrane may show a perforation or a cholesteatoma can be identified as a white mass behind the tympanic membrane or coming through the external canal from a perforation. Cholesteatoma is another condition of the middle ear, and it is a growth of the skin of the external ear of the drum into the middle ear. And this is normally caused by chronic retraction pocket of the tympanic, creating a persistently high negative pressure of the middle ear. The skin forms a sac that fills the degenerated skin and sebaceous materials.